Hi, this lecture is about pediatric femur fracture. A good source that you can use is this book written by myself and Dr. Naga. What are the objectives of this lecture? First, we'd like to speak about the epidemiology and the anatomy of the pediatric femur fracture. Then we're going to speak about the general management of children with pediatric femur fracture. And then we're going to speak about how to identify femur fracture that are due to non-accidental trauma or child abuse. And then we're going to speak about the treatment options for different types of pediatric femur fracture. So the epidemiology, pediatric femur fracture is about 1.5% of pediatric fractures. This is about 28 cases per 100,000 child per year. It's more in male, so it's 3:1 male to female ratio, and children older than 3-year-old has the highest incidence of having pediatric femur fracture. So what are the mechanisms of injury for pediatric femur fracture? For children less than 1 year old, you have always to exclude non-accidental trauma, as we're going to discuss extensively in the second part of the lecture. Usually for young children and toddler, the reason for femur fracture are fall. Children from 4 to 10 can have femur fracture if they are hit by a car, as we're going to see in the next slide. For adolescents, most of the femur fractures come from recreational activity and sport activity, and of course motor vehicle collision can cause femur fracture in all age group. This is a picture here for the mechanism of injury if it's pedestrian hit by a car. We said the juvenile, so the patients from 3 to 10, their height when they are hit by a car will make them go underneath the car, so they may end with a triad of a femur fracture, abdominal injury, and head injury. So usually the femur fracture that is associated with the pedestrian, it's usually around the age of from 3 to 10 because their height will make them go underneath the car, ending with femur fracture, abdominal injury, and head injury. So the physical exam for a patient with femur fracture is a high energy injury, so you have to do a complete exam. You have to do exam of the head, chest, and abdomen and other skeletal segment, meaning that you have to assess other extremities to make sure that there is no associated fracture. You have to palpate all bony parts because the femur fracture causes something what we usually describe as distracting injury, meaning that the pain from the femur fracture will distract the patient from other injuries that he may have. So if you see is one of my patients, he has a femur fracture, in the same time he has a humerus fracture. However, patient will be complaining of pain in the thigh, and they may completely ignore this arm pain because the pain from the femur fracture distract them from other injuries. So you should actively palpate all the bones, all the other extremities to make sure that he has no other injuries that has been distracted by the pain from the femur fracture. It's also very important to assess the neurovascular bundle distal to the injury because the femur fracture, especially the distal femur, may cause injury to the nerves or the vessels, so you should assess the pulse and the nerves of the extremity distal to the fracture, and then once it's safe you should either splint the fracture or apply traction. For the radiographic evaluation of femur fracture, X-ray of the pelvis should be obtained, and for the femur you should get AP and lateral. And in these pictures you have to see the hip joint and the knee joint. This will allow you to see if there is any associated fractures in the pelvis, and also will allow you to see. There are many classifications for femur fracture. First, it can be classified either open or closed. Open fractures are fractures that has an associated wound and the wound is in continuity with a fractured hematoma. Open fracture always carries some risk of infection. Also, the fracture can be classified according to the location of the fracture to either proximal, the epiphyseal, or distal. The proximal fracture is the fracture of the neck. The epiphyseal is the shaft fracture. The distal fracture, it can be at the level of the physis, so it's a physeal injury, or slightly above, which is metaphyseal. Also, the fracture can be classified according to the fracture pattern. Common fracture pattern are either transverse, spiral, or oblique. Also, it can be comminuted or green stick. In the next few slides, we're going to speak about non-accidental trauma, or what's commonly known as child abuse, and its relation to femur fracture. There are some cases of femur fracture that are associated with non-accidental trauma. However, you have to remember that it's not easy to recognize a child with non-accidental trauma. It's not easy in every femur fracture to know if this is due to accidental injury or non-accidental trauma. So what are the risk factors that can point towards non-accidental trauma? As we said, it's not easy to detect if a case of femur fracture is due to child abuse or non-accidental trauma, or it's due to a normal accident. Why? Because non-accidental trauma or child abuse can affect children of all ages, all socioeconomic backgrounds, and all family types. And you have to remember that 65% of cases of child abuse or non-accidental trauma actually present with an isolated long bone fracture. So it's a very high percentage of cases of child abuse that present with isolated bone fracture. As we said, non-accidental trauma or child abuse can occur in families of all types and all social backgrounds. However, there are certain risk factors that should raise your suspicion towards non-accidental trauma or child abuse. Young and single parents, drug abusing parents, and parents who were abused as kids, all these are risk factors for non-accidental trauma. Regarding the children, firstborn children, premature infant, and disabled children, these are more prone to have non-accidental trauma. Also stepchildren and families with low income. So for parents, single parent, young parents, drug abusing parents, and parents who were child abused when they were young, all this carries higher risk for children, firstborn, premature, disabled, and stepchildren, and families with low income. So these are the risk factors for non-accidental. So why it is important to make sure that you detect a case of non-accidental trauma and know if this femur fracture is due to accidental or non-accidental injury. It is important to detect femur fracture or that are due to non-accidental trauma because if it is unrecognized and this kid goes back to home, there is a 25% risk of another serious injury and about 5% risk of death. So it is very important to detect if an injury or an isolated bone fracture in general, and specifically if it's a femur fracture, is due to accidental or non-accidental, because if it's due to non-accidental or child abuse and this child goes home, there is a 25% risk of a serious injury and possibly even this 5%. So you should recognize isolated bone fracture that are due to non-accidental trauma and put a child in a safe environment. And we're going to discuss this in the next slide, that child abuse is common and it's actually the second leading cause of mortality of infant and children in the United States. So it is important to protect these children from further injury. As we said in the previous slide, non-accidental trauma is not rare, it's actually widespread. Child abuse affects about 1% of children per year. This is a very high percentage, and there is about 1 million children abused annually in the United States. So it's not rare, and it is something that you need to keep in mind. And of course, in cases of femur fracture, you should always try to see if this is due to accidental or non-accidental trauma. So what are the signs of non-accidental trauma? What are the things that should raise your suspicion towards having child abuse? First, inconsistent history of injury. What does this mean? It means that you are going to hear something from the mother and then you can hear something different, example from the boyfriend, and then the story changes next day or when another provider comes to ask about the history. So the mechanism of injury will be inconsistent and will be changing all the time. There may be delay in presentation. So for example, the fracture happened like 2 or 3 days ago. So this is a red flag of possible non-accidental trauma. And sometimes the mechanism of injury that is reported by the family is inconsistent with the injury. So for example, they may say the child fall from the couch and he has like 3 fractures. That does not make sense. So in these cases, you have to think about child abuse, and the parents or the caregiver may be either hostile against the medical providers or they may be indifferent. So these things in the history and in the presentation should raise your suspicions of having possible child abuse. Inconsistent history, delay in presentation, a reported mechanism that is insufficient to produce the injury, and the parents may be hostile or indifferent. What do you do for the evaluation? Non-accidental trauma or child abuse needs team approach. So the orthopedic surgeon may be actually the first one to recognize it, but to address the problem, it needs the pediatrician, it needs the social worker, sometimes it needs law enforcement and child protective service. And you have to remember that the health providers are waived from liability if they report child abuse in good faith. So if you report that you think that this injury may be due to non-accidental trauma and it turns not to be like this, you are waived from any liability so long you were reporting this in good faith and trying to prevent the child from having any other injuries. So if you reach to a wrong diagnosis, if this case was actually due to accidental trauma and you addressed it as non-accidental trauma, you're waived from liability so long you did this in a good faith. So now let's go back to our topic with femur fracture. So what are the cases of femur fracture that you should suspect non-accidental trauma? The most important thing, if you have a femur fracture in a non-ambulatory child. So if you have a child less than 12 to 16 months non-ambulatory and he gets a femur fracture, that should raise your suspicion of possible non-accidental trauma. Here is one of my patients. He is 11 months and he got a femur fracture and it turned to be non-accidental trauma. He was treated in a spica cast. Another red flag and another thing that should raise your suspicious if there is another fracture. So actually this patient had a clavicle fracture, if you can see here. So this also another thing that should raise your suspicious of non-accidental trauma. So femur fracture in a non-ambulatory child less than 16 months is a red flag and should raise your suspicious of possible non-accidental trauma. Regarding spiral fracture, actually most of the non-accidental trauma are not spiral. It's only 1/3 of the cases of non-accidental trauma are spiral fracture. And spiral fracture actually is more common in accidental injury than in non-accidental trauma. So despite that the spiral fracture is something that we usually talk about frequently, it's actually more common in accidental trauma, and it's only 1/3 of bone fractures in non-accidental trauma or child abuse is spiral fracture. I'd like to refer you to this lecture that will give you more details about non-accidental trauma, signs, and how do you manage and what are the x-ray pictures. So you can click here on the this link and you can go back to my video about non-accidental trauma. This is a complete lecture only for this topic. So after we have discussed the topic of the femur fracture and its relation to non-accidental trauma, let's speak now about femur fracture anatomical classification. What are the types of the femur fracture regarding its anatomical classification? Proximal femur fracture, this part of the femur is called the proximal femur fracture, which is the head of the femur, the neck, and the trochanteric area. And then the diaphyseal femur fracture, which is we usually refer to as the femoral shaft. It's between the proximal part and the distal part. The distal femur, this part of the femur is called the distal femur, and it involves the growth plate here, or the physeal injury, and the metaphyseal part above the growth plate. So there are three parts of the femur from its anatomical classification: proximal femur, diaphyseal, and distal femur. So what is the management of the diaphyseal femur fracture or the shaft fracture? So this is a brief introduction, and we're going to speak about these methods in the next slide. But to classify the treatment options, it can be non-surgical or surgical. The non-surgical is the Pavlik harness or the hip spica, and we're going to see examples for these. The surgical can be either plate screws, external fixators, or some sort of a nailing, either flexible nailing or rigid nailing. We're going to go through these options in detail in the next slides. So for very young kids, less than 6 months, they can be managed in a Pavlik harness. So if you see here, this is a femur fracture in a 4-month-old. You can see here there is a femur fracture. So these kids can be treated in a Pavlik harness. The Pavlik harness is mainly meant to be treating hip dysplasia. However, it can be used for treatment of femur fracture in children less than 6 months. So for children from the age of 6 months to about 4 years, if they get a femur fracture, as you can see here in this x-ray, this is a femur fracture in a 3-year-old girl. A spiral shaft fracture. She was treated with immediate spica cast. The spica cast, it goes all the way from the chest to the end of the extremity on the affected side, and it goes to above the knee on the other side. And usually the spica cast is left for about 4 to 5 weeks till the fracture healed. So as we said in the previous slide, kids, infants less than 6 months treated with Pavlik harness. From 6 months to 4 years, usually the treatment is immediate spica cast. As you can see here, the spica cast will go from the chest all the way to the end of the extremity on the affected side and above the knee on the other side. Application of the spica cast requires lots of help. It's not an easy procedure, and it requires lots of expertise. So here the child is under anesthesia on a specific table called spica cast, and then it requires about 2 to 3 people to apply a good spica cast. You have to make sure that all the bony prominences are well padded, and also we put these towels here and we remove them at the end to make sure that there is a space for the stomach to expand. Again, application of a spica cast is a technical procedure, and it requires lots of expertise and lots of help. It's usually the treatment of choice for children from 6 months to 4 years. After we have discussed the closed method for treatment of femur fracture, the Pavlik harness and the spica cast, let's talk about the surgical open methods for treatment of pediatric diaphyseal femur fracture. There are 4 main types: the external fixator, nailing, whether flexible nailing or rigid nailing, and plate and screws. We're going to speak about these types of fixation in the next slides. So the first surgical method for treatment of femur fracture is external fixators. External fixators are pins that are connected to each segment of the bone, and these pins are connected from the outside with a bar. What is the advantage of external fixator? It has minimal blood loss because in most cases you don't open over the fracture, so there is no bleeding. It's relatively quick to put them, and there is less incidence of deep infections. So if you're worried about deep infection, like cases of open fracture, as we said, any open fracture carries risk of deep infection. It's better to use external fixator, and it can use in provisional fixation. So if you have a child that has a femur fracture, he's not stable, you can use them, put them quickly as a provisional fixation, and then if needed, it can be later changed. So this is a case of a femur fracture in a skeletally immature patient. You can know it's skeletally immature because you can see the physis here. So that tells you that this is a child who did not reach full skeletal maturity yet. And this is an open femur fracture. How do we know it's open? You can see obviously here that the distal part of the proximal fragment is outside the body. So this is definitely a grossly contaminated wound. Once you can see the bone out of the wound, that's automatically become open fracture type 3. So you can see here definitely there is a big piece of the bone here outside the wound. So this is a grossly contaminated open fracture type 3. So this is a good indication to put external fixator. Also, this patient had an associated tibial fracture, so you want to do a method of fixation that will not involve too much blood loss and is relatively quick. And that's what was done here. So this is an external fixator, 2 pins into the proximal fragment, 2 pins into the distal fragment, and these pins are connected from outside with a bar here, as you can see. Here is the lateral view, and in the lateral view also you can see the fixation of the tibia. So this was a perfect indication to put an external fixator. This is a patient who has multiple trauma. He has a femur fracture, he has a tibial fracture, it's an open fracture, so using the external fixator was good. Again, the advantage is it's quick, it does not involve too much blood loss, and it's less incidence of deep infection. So this was a perfect indication for this case. Despite the advantage of external fixator, we don't use them that often currently in treatment of femur fracture in children. The main reason that we don't like the using of external fixator is the high incidence of refracture. It's about 20%, meaning that after the patient heals and we remove the external fixator, the patient gets another fracture either through the primary fracture that he had or through one of the pinholes. It's about 20%, which is a very high chance. So we currently don't like to use external fixator in most of the cases of pediatric femur fracture. Also, there is some certain degree of malalignment and malrotation and limb length discrepancy with using the external fixator. However, the main reason that we don't like to use them is the refracture. Other disadvantage of the external fixator is the pin tract infection, means that at the level of the thigh, where is usually lots of muscles and fat, there will be motion between the skin and the pin, and you will get pin tract infection. So children in general don't like to use external fixator and don't tolerate them very good at the level of the thigh because of the pin tract infection. So again, disadvantage of using the external fixator, it's the high incidence of refracture. There is also some malalignment and malrotation and limb length discrepancy. And another reason not to use them is the pin tract infection, which is more common at the level of the thigh, and the patient don't like external fixators in general at the level of the thigh. In brief, external fixator, 2 pins or 3 pins attached to each segment, and then from the outside they are attached with a bar. They have the indication currently it's used in open fractures or for provisional fixation, or if the patient is relatively unstable. However, they have significantly higher complication rate, and now we have other methods of treatment of femur fracture in children, so they are not commonly used as much. So after we have discussed the external fixator as a treatment for femur fracture, the second surgical type is flexible nail. Sometimes it's referred to as elastic nail because these nails can be bent, so they are not rigid. The indication for using a flexible nail in treatment of pediatric femur fracture is a transverse mid-shaft femur fracture in a child that is less than 100 pounds or about 43 kilos. So like in this case, there is a transverse fracture with a small butterfly. So this is not very unstable fracture. A mid-shaft femur fracture in a child that has to be less than about 100 pounds or 43 kilos. So you see here, this is a femur fracture. It's treated with 2 elastic nails. This is another indication here. One of my patients, a right femur fracture, transverse. You can see here there is no comminution, and with using 2 flexible nails that we put from the knee going up, we can get very good alignment, as you can see here. So this is called flexible nail or elastic nail because it can be bent. It's introduced usually from the lower part of the femur, and the main indication, as we can see here, transverse mid-shaft femur fracture in a child less than 100 pounds. So the advantage, it is a small procedure. Usually it can be done quickly. There is only 2 small incisions in most cases at the level of the knee. What are the disadvantages? It's not very stable. As you saw, these pins can be easily bent. So if you have a child that is more than 100 pounds, it will not be a stable fixation. Or if there is an unstable fracture, if for example a spiral fracture, there will be some shortening if you use the flexible nail, or if there is marked comminution. Also, it cannot be used in proximal or distal fractures, so it can be only used for shaft fracture. So advantage of flexible nail, it's quick, small procedure, minimal amount of bleeding. The disadvantage, they are not very stable. You cannot use them in heavy children, or if the fracture is unstable, if there is marked comminution or a spiral fracture. Also, it cannot be used for proximal or distal fracture. So the third method after external fixator and flexible nail is rigid nail. Rigid nail is more stable fixation. It can be used to treat pediatric femur fracture. The rigid nail has locking screws. It means the screw that go through the nail and capture both cortices. The idea of this locking nail, it gives stability regarding the rotation and the length of the femur. So a rigid nail can be used for pediatric femur fracture. It's much more stable than flexible nail. You can see here a femur fracture in a pediatric patient. You can see the growth plate here and here. So this is a skeletally immature patient, and the fracture was treated using a rigid nail. So here is the rigid nail. It has a locking screw proximally, locking screws distally, and a few months down the road, the fracture had healed, as you can see here with the callus. The advantage of rigid nail, it's much more stable fixation. The locking screws allows you to have rotational control and also control of the length. The disadvantage, there is some risk of affecting the blood supply of the proximal femur, and I'm going to show that in the next slide. So this is the picture here for the blood supply of the proximal femur. Here is the femoral artery, gives the medial and lateral femoral circumflex, and these gives the blood supply for the proximal femur here. The traditional nails go through the piriformis fossa, which is this area here. In pediatric patient, this area here comes a little bit closer to the blood supply, and there is some risk of affecting the blood supply. So if you see this picture here, this is the piriformis entry, and in children the piriformis entry comes close to the blood supply coming from the medial femoral circumflex artery. However, we don't use that method of piriformis entry nail in pediatric patient. We now use something called lateral entry. So in adult, there is the piriformis entry or the trochanteric entry. In pediatric patient, to be even in a much better or much safer position, we go to something called the lateral entry, which is further away from the blood supply. So the blood supply to the proximal femur comes from here, or if you're seeing it from above, it comes from here. The traditional methods, which is the piriformis, comes very close to this in children. There is another form of entry called the trochanteric in adult used here. However, in a pediatric patient, to stay away from the blood supply, we go to a lateral entry, which is in this spot. So it is at this level here, the lateral entry nail. So it is away from the blood supply. So the new design for the adolescent rigid nail are much more safe regarding the blood supply to the proximal femur than the old designs. So here is one of my pediatric patient. You can see the growth plate here and the growth plate here had a femur fracture, unstable, and so we decided to use a rigid nail, and the new design of the rigid nail is called the lateral entry nail. And again, the lateral entry nail don't start at the piriformis, which is extremely close to the blood supply, and don't start at the tip of the greater trochanter. It actually goes even further away. It goes from the lateral part here of the greater trochanter to stay away from the blood supply, and these are with the new designs very safe regarding the affection of the blood supply. So we discussed first the external fixator, the second thing was the flexible nail, the third thing was the rigid nail, and among the rigid nail, the one that we use now is the lateral entry nail to stay away from the blood supply, which is in this spot, which comes close using the piriformis nail. So right now we use the rigid nail lateral entry to stay away from the blood supply. The advantage of these nails, they are very strong fixation. They can be used with unstable fracture. So we discussed the three previous methods for treatment of femoral shaft fracture, which is external fixator, flexible nail, and rigid nail. The last method is the femoral plating. There is two types of plating, the classic compression plating and the new technique, which is the submuscular plating. The submuscular plating depends on the idea of minimal stripping of the soft tissues and passing the plate above and below the fracture and fixing it, as we're going to see in the next slides. So this is like a classic compression plating, which still gives good result. You open through the fracture and you apply a plate and screws and usually in most cases it gives a very good result. This is a good treatment if you don't have the facility of using intraoperative fluoroscopy, which is the C-arm. Also, there is some cases in which getting the reduction is extremely hard, and the only way to obtain the reduction is to open through the whole fracture. So this is the classic compression plating. The new technique of the submuscular bridge plating, as we said, you do 2 small incisions and you pass the plate. So you see here a pediatric patient has an unstable spiral fracture. You can see the lines of the fracture in this view. This patient is about 40 kilograms. It's an unstable fracture because it's a spiral fracture. So we decided in doing submuscular plating. A patient was positioned here. We identified the upper part of the femur through the C-arm. Again, this if in order for you to do submuscular plating, you have to have an intraoperative C-arm. And then we decide on the length of the plate, and then after that we pass the plate from the proximal part to the distal part, or you can also pass it from distal to proximal, and you fix it. You can see here the intraoperative picture of the plate. After we decide on the length of the plate, we bend the plate to match the flare of the femur, and we start putting the screws into the plate to fix the fracture. This is the end result here. You can see only 2 small cuts, and after passing the plate, we start fixing the screws to push the plate toward the bone and get the reduction. So you can see here the screws fixing the plate, and this is the end result here with the plate over the bone and fix it proximally and distally. You can see here the fracture. With time, this fracture healed with secondary healing, and you will find a callus here in that area. So this is another example, 13-year-old female with mild osteogenesis imperfecta. She has a femur fracture with obvious rotation. She was treated with submuscular plating, 2 small incisions, and then the plate was passed underneath the muscles and fixed proximally and distally. And this is 5-month follow-up. You can see a full range of motion and good signs of healing here over the fracture, and good signs of healing here in the lateral view. So this slide summarizes what we discussed about the treatment of the shaft fracture for stable injury. For children less than 4 years old, we use the Pavlik harness in the first 6 months of life, and then the spica cast till the age of 3 to 4 years old. Children from 4 to 12 years old, we usually, if it's a stable fracture, we use elastic nails. So for stable fracture, very small infant, we'll use Pavlik harness. After that, we use a spica cast. Starting from the age of 5 years, we usually fix them using the elastic nail or the flexible nail. For unstable injury, if it's the child is less than 12-year-old, we usually use submuscular plating. If the child is older than 12-year-old, we'll use the trochanteric lateral entry nail, the new design nail. So this summarizes the femoral shaft fracture. Stable, for small kids, very small infants, will use Pavlik harness. After that, we'll use the spica till the age of 3 or to 4 years old. Starting from the age of 5, we'll use elastic nails. If it's an unstable injury, if the child is less than 12, we usually use submuscular plate, and if it's older than 12, we usually use the trochanteric lateral entry nail. This, of course, there may be some changes regarding every case, but this is an overall for the treatment of shaft fracture. In cases of polytrauma, you can use open fracture. External fixator should be used. If you are in a place that you don't have a C-arm, the classic compression plating, the classic plate and screw can be used. So for polytrauma or for open fracture, external fixator, or if there is a facility that doesn't have an intraoperative C-arm, intraoperative fluoroscopy, using the classic plating technique is the solution. So after we have discussed the femoral shaft fracture, let's speak about proximal femur. The proximal femur is the proximal part of the femur, the upper part of the femur, which include the femoral head, the growth plate, the femoral neck, and the trochanteric area. This fracture is actually not common. However, it is important fracture because it is considered as urgent fracture because it can affect the blood supply going to the proximal femur. If you see here, the blood supply comes from the base of the neck and goes up, as you can see in this picture here. So when you get a fracture of the proximal femur, it can affect the blood supply going to this area. Also, when you have hematoma here into the capsule, it can compress on these blood vessel, causing affection of the blood supply. So despite that the proximal femoral fracture in children is not common, it's an important topic because it's considered an urgent injury because it may have an effect on the blood supply of the proximal femur, as we see by two mechanisms. It can either injure the blood supply going from distal to proximal, going from the base of the neck to the head, or by the hematoma here, it can compress on the blood supply going to the head. This fracture is usually considered an urgent injury and it should be treated as soon as possible. So there is a classification for this fracture. Type 1 is where it happened through the growth plate, type 2 happened through the neck, type 3 happened through the base of the neck, and type 4 happens in between the greater and the lesser trach. The more you go distally, so this one has very low chance of having affection of the blood supply, and this one has a much higher chance of affection of the blood supply. So the more you go distal, the less chance of affection of the blood supply. The more you go proximal, the higher chance of the blood supply. So proximal femur fracture, it's not common. However, it's an important topic because it's an urgent injury. It may affect the blood supply going to the proximal femur. So here is an example of a fracture of the neck. You can see here, this is a fracture of the neck. It's a proximal femur fracture in an 11-year, 6-month-old boy. So this was taken as soon as possible to the OR. Here we obtained a reduction. So these are intra-operative C-arm or fluoroscopy. We obtained the reduction here of the fracture. And then before fixing the fracture, we used a syringe here into the joint to aspirate the joint so that we can decrease the compression over the blood vessels by the hematoma. And then the fracture was fixed using 3 screws. If you notice, the screws did not cross the growth plate here to avoid injury to the growth plate and avoid preventing the growth through the growth plate. Another example here, so this is a little bit more distal fracture. It's the type 4, the intertrochanteric fracture. You can see here the lateral view. This is a 10-year-old. And this was openly reduced and fixed using this device, which is a sliding hip screw. So after we discussed the proximal femur fracture and the shaft fracture, let's speak about the distal femur fracture, the lower part of the femur. There are 3 main types of the distal femur fracture. Minimally displaced supracondylar fracture. This is a common fracture in infants. It's minimally displaced fracture that usually does not require more than splinting. And there is the physeal injury, which happened through the growth plate. And the third one is the metaphyseal injuries, which happens just proximal to the distal to the physis. So here the physis is here, and the metaphyseal fracture happens in this part. So if we would like to speak about the anatomy of the distal femur, the distal femur physis or the distal femur growth plate is the fastest growing physis of the lower extremity. It grows about 1 centimeter per year. So it's a very active area here, and there is the most growth of your lower extremity comes from the distal femur, and it stopped growing, or what we use the word fuses means these two parts become fused together around the age of 15-year-old in boys and 14-year-old in girls. So the proximal physis, it's a very important physis. It's the most rapidly growing physis. It grows about 1 centimeter per year. It stopped growing or fuses at the age of 14-year-old in girls and 15-year-old in boys. So the first type of the distal femur fracture is the minimally displaced supracondylar femur fracture in infants. It happens in young infants. It can be associated with non-accidental trauma or child abuse, as we discussed in the first part of the lecture. This fracture is minimally displaced, so it does not require reduction. The treatment is either spike a cast or high above knee splint or a cast. Physeal injury, the second part of the distal femur fracture, the Salter-Harris injury. It means that it happens through the physis. Most commonly is supracondylar type 2, so the injury goes through the physis and then continue into part of the metaphysis. In this area, the fracture can have an effect over the popliteal vessel. We're going to show a picture for that, and it can cause growth disturbance. So the growth disturbance of the distal femur fracture, it is very common. The distal femur physis can easily be affected if it has an injury to it. The one which has the highest instance of growth disturbance is the Salter-Harris type 4, which is the partial articular type. And the one which has the lowest incidence is the Salter-Harris type 1. Generally, 50% of the physeal distal femur fracture will have some sort of growth disturbance. Like you can see here, this is one of my patients. She has old physeal injury here of the distal femur, and you can see there is a growth disturbance here in the form of limb length discrepancy with 5 centimeters. This patient had lengthening through the external fixator to correct this amount of shortening. So physeal injury of the distal femur acutely, it can have an injury to the popliteal vessel. We're going to show a picture for that. And on the long run, it may have growth disturbance. Collectively, about 50% of them will have growth disturbance. The growth disturbance can be in the form of a deformity or limb length discrepancy. This is an example of one of my patients, and you can see there is a 5 centimeter limb length discrepancy. The affected side is shorter than the other side, and this patient required to have lengthening to correct that shortening. The management, you have to assess the neurovascular bundle in the affected side. You have to make sure that the vessels, there is good pulse at the distal part of the extremity, so and that there is no injury of the vessel. And you have to obtain urgent closed reduction or open reduction to avoid compression over the popliteal vessel, and then the fixation usually by smooth K-wires if you're planning to cross the physis, or screw fixation. This is an example of an open Salter-Harris type 1 in an 11-year-old boy. So this is type 1, so it happened through the growth plate. Here is the shaft of the femur outside the wound. You can see it here, and this is the fracture that happened through the growth plate, and this is the epiphysis. This is an anteroposterior view. So to assess the blood vessels, we got a CT angio, and you can see here, luckily in this case there was no affection of the blood supply, and you can see here the vessels did not got injured. In some cases it can be compressed or even torn. And then the fixation by smooth K-wires crossing the physis, and you can see here after the closure, and these are the 2 pins. So this is another example for fixation. This is Salter-Harris type 2, so the fracture went through the growth plate, and you can see here a part of the metaphysis is with the distal fragment. So this is Salter-Harris type 2, so this was reduced here, and then it was fixed using screws that did not go through the growth plate. So if you're planning to go through the growth plate like this, you use a smooth K-wire as we saw in the previous example. If you have a part of the metaphysis in Salter-Harris type 2, and this part is big enough, you can fix it using this part with the screws that don't cross the growth plate. The third part of the distal femur fracture is the metaphyseal fracture. So we spoke about the first part, the minimally displaced supracondylar fracture in infants. The second part is the physeal. The second type is the physeal. The third part is the metaphyseal, which happens a little bit more proximal here than the growth plate. It's more in adolescent, and it's more with high energies. And you can see here this fracture here happened through the metaphysis, and it was fixed using plate and screws. This child had actually a shaft fracture and metaphyseal fracture that also went through the epiphysis, so it was a multi-level fracture of the femur. And he was, you can see here in the CT how amount of the comminution. There was actually also a patella fracture associated with that. So all this was fixed using a long plate to fix the epiphyseal, metaphyseal, and the diaphyseal fracture. So here is the 3-month follow-up. You can see the healing of the diaphyseal fracture and healing of the metaphyseal and the epiphyseal fracture, and with a good range of motion. Here, this is the affected side. The other side has just injury from soft tissue injury, but the affected side was the right side, and you can see very good range of motion. And of course, long-term follow-up showed that there is a 5 centimeter limb-length discrepancy because of the injury that happened through the growth plate in this area. So with this, we finish the femur fracture. The take-home messages is a femur fracture associated with high energy injuries. So you should do a very good exam to examine the whole patient, assess the head, the abdomen, other extremity. If you have a femur fracture in non-ambulatory child, always be thinking of non-accidental trauma. Regarding the femur shaft fracture, there are many treatment options depending on the stability and the patient age, as we has discussed. For the proximal fracture, again, it's not common injury. However, it's an important because it should be treated on urgent basis to avoid affection of the blood supply. For the distal femur fracture, remember it can be associated with vascular injury, so you should be obtaining close reduction as soon as possible, and always warn the family that there may be eventual growth disturbance that happen through due to these injuries. Thank you. Please remember that all my videos are for educational purpose only, and please consult your doctor before any decision.